Assalamu alaikum. It's my great pleasure again and honor to introduce today distinguished speaker, Dr. Sameh Galal, consultant of Pediatric Ophthalmology and Strabismus Research Institute of Ophthalmology in Egypt. Today, Dr. Jalal will be presenting a lecture on the accommodative esotropia, uh, especially with the statement of not easy as it looks, one of the most common topic we see in the clinic. So please welcome with me Dr. Sameh Jalal. Dr. Sameh Jalal, mic is yours.
Thank you, Dr. Muhammad, and thank you, Dr. Abdurrahman, for preparing this nice session. And welcome all audience for attending. And starting with a topic like accommodative esotropia, I am very much interested in telling or speaking about accommodative esotropia, mainly for two reasons. The first one is almost more than 50% of accommodative esotropia cases are presented to general ophthalmology doctors. So all ophthalmologists should be aware of accommodative esotropia details. The second is we have many chaos or many misunderstanding points about the accommodative esotropias that can lead to dangerous or devastating results in management of esotropia. Especially when you are speaking about esotropia, many times I hear about what's esotropia, because esotropia is very simple. We know we have hypermetropia that will put hypermetropic lenses or plus lenses, and it will be totally corrected. This is the whole story. So it's a very nice story and easy. It doesn't deserve uh, anything uh, additional to mention. And when I tell no, it's not that easy. It has some different points. They will tell me, no, no, we know well, because some cases are partially accommodative. We do full correction and they come with undercorrected strabismus for which we have to send or to do surgery. So it's a very simple equation because we have hypermetropia that will lead to accommodation, and the accommodation will lead to convergence, and the convergence will end up with esotropia. So let me ask you one question. Is it that easy equation of having one diopter of accommodation that will cause some convergence? And you all know about ACA ratio, what's called accommodative convergence. And usually it's measured in a percentage. It's called ACA ratio or accommodative convergence accommodation ratio. That points at we have one diopter of accommodation that will lead to some numbers of convergence in prism diopters, which is normally from 3 to 5 prism diopters. So usually we have accommodative convergence accommodation ratio of 3 to 5 prism diopters. Then you will tell me again, it's very easy because if you have hypermetropia of +4, we can accommodate to a certain number of diopters, let's say some diopters of accommodation, which are 4 diopters, that will lead to convergence that will range from 12 to 20 prism diopters of convergence. So esotropia will be there, of esotropia of 20, 12 to 20 prism diopters. But let me ask you a question. Does accommodative esotropia occur in any hypermetropic patient? Because all of you see cases of hypermetropia, but you see many times you see patients +4 or +5, and they are not esotropic. They are hypermetropes, and they are not corrected or undercorrected, and they are not esotropes. And the answer is frankly no. Not all hypermetropic patients are esotropic. Then we should ask why, and we have many reasons for that. The first reason is we have some what's called fusional divergence amplitude. It's a corrective compensatory mechanism that will lead to divergence that will correct for any occurring mishap of overconvergence. So whenever you have some horizontal convergence that will cause the eye to get out, it's called fusional divergence, and each one of us has some amplitude of that divergence. It's called fusional divergence amplitude. And usually it ranges from 6 to 10 at distance and about 12 at near. So if you have esotropia of 12 prism diopters, it can be corrected for near, or we have 6 to 10, they can be corrected for distance. So it's very simple to have fusional divergence amplitude that would correct for, it will correct for any occurring convergence. Many times it happens when you have slowly occurring esotropia. This fusional divergence increases and you have large fusional divergence amplitude. So you can compensate for your esotropia that will occur according to your accommodation and convergence by the fusional divergence amplitude that will correct your esotropia. Then we'll come to the second reason because you all know something called high ACA ratio, but no much people know about low ACA ratio because sometimes if you have normal ACA ratio from 3 to 5 prism diopters, sometimes it's below 3. So if your ACA ratio is below 3 and you have hypermetropia, let's say 2 or 3, then you will have low accommodation convergence amplitude or low accommodative convergence ratio. So you have less convergence, less esotropia that can be controlled by the normal fusional divergence amplitude. Third reason is very common when you have uncorrected very high hypermetropia, let's say +7 or more. Because the main initiative or trigger for accommodation is a blurred image of hypermetropia. It's focused in front of the retina, so you can't see well. Then you can accommodate to bring the image back to be focused on the retina. But what if you have very high hypermetropia, +7 or more? So you have no initiative. Like I'm shaking hands at you when I'm standing up at 4 kilometers distance. So you don't see me to just say hi. But when I'm very near, maybe 1 or 2 meters, you can see me well. Then you can see my shaking hands and you can come to shake hands with me. Then if you have +4 or 5, you are more prone to be accommodative esotropia than when you have +7 or more. Then take care not to do it yourself. One of the very common scenarios when you have very high hypermetropia in a child, let's say 4 to 5 years, coming to your clinic for the first time with no esotropia, but just complaining of anything else like chalazion, blepharitis, BC, headache. Then you examine and you do your cycloplegic refraction and you discover this child is +8 or 9. Then what will you do? You will be sympathizing with the child and you'll not start giving him his +9 or 8. You'll start giving him +4 or 5. The child will come to you next time with esotropia with glasses because you transformed him from high hypermetropia to moderate hypermetropia. Then he can accommodate and develop esotropia for which. So take care not to undercorrect children under the age of 5, not to cause partial correction and overconvergence that will lead to esotropia with glasses that will correct, it will correct completely without glasses. Last reason is very strange because many times the child has his own choice. It's called personal psycho-personal aspect. Sometimes you have a child of +4 and another one with +4. So the first one decided to accommodate subconsciously and have convergence and esotropia, but he paid too much, paid accommodation with headache to have the value of a clear image. The second one didn't want to pay the payment that for clear vision because let's relax, have aligned eyes. It's not a matter to see well or clear, but will not have esotropia or headache. So many times you can find a child with amblyopia, properly aligned eyes without correction, and he decided to have aligned eyes without headache. Another one will have relaxed ciliary muscles, no headache, no accommodation, no convergence, and these. Then let's jump to our next point. And this is a very common prescription. I'm sorry for those who can't read Arabic, but I'll translate it to you because many times when we have a patient with hypermetropia and you tell him, just go home, we'll give you cyclopentolate eye drops, use it 3 times daily for 3 days, and come in the fourth day or the end of the third day to do your cycloplegic refraction. And I think many doctors do that. And it's a very, very common mistake because the duration of action of cyclopentolate is doesn't exceed 24 hours. So it's usually 18 hours. So the effect of the second day drops will resolve and it has no cumulative effect. So if you want to give cyclopentolate, it has its own protocol, not to be used with 3 days. And This is the catch of our session today. Please remember it by well and copy it in your clinics, because you have to know each one of the dilating eye drops and what is the exact action and duration of action of which. Because we have many drops. The first one is atropine, and it's called the father and the mother of cycloplegic eye drops or dilating eye drops. It's causing dilatation and cycloplegia. Dilatation of the pupil and cycloplegia, which is the relaxation of the ciliary muscles. But a very potent cycloplegic, it's not that strong mydriatic. It causes maintained dilatation, but it doesn't cause full dilatation. So if you put atropine eye drops for any patient for many times, you will never end up with fully dilated pupil. You will have mid-dilated pupil, and you will have completely relaxed ciliary muscles. So you have complete cycloplegia. So when you have patient with atropine, you have to know the duration of action of atropine, because it lasts for mydriasis 7 to 10 days, and for cycloplegia up to 2 weeks, and sometimes may extend to 1 month. So if you give atropine 3 times daily for 3 days, it will have accumulating effect. So the cumulative effect with atropine will last for 3 days or more. Then if you call the patient again in the fourth day to do cycloplegic refraction, you will have full cycloplegic refraction. So if you are interested to know your full cycloplegia of your patient, give him atropine 3 times daily for 3 days. It's usually used for many reasons, but our context today is about accommodative esotropia. So when you are giving atropine eye drops, you can give it to the patient 3 times daily for 3 days. It's not a matter of doing the same with cyclopentolate, because the time of duration of action of cyclopentolate is maximum 24 hours for both cycloplegia or dilatation. So if you are giving a patient 3 times daily cyclopentolate, it will not work for 3 days. It will resolve, and second day will come with the second effect. So at your clinic, if you want to give the patient cyclopentolate, usually it causes maximum cycloplegia up to 30 minutes of putting the first drop. So if you give the patient 2 drops of cyclopentolate at minute 0 and after 5 minutes or 5 to 10 minutes, you can do your cycloplegic refraction with having comparable results to atropine with full cycloplegia after 35 to 50 minutes after putting the first drop. Then it's not causing full dilatation like his father atropine. So cyclopentolate and atropine will never cause full dilatation. The one that can do, sorry, the one that can do complete cycloplegia is the tropicamide. Tropicamide is used under many names in different countries, like Midrasil or Midrapid or any other names. But finally, it's a tropicamide. It's a very strong dilator of the pupil, but it's very weak cycloplegia. So if you are interested to do just fundus examination or simple refraction revision, tropicamide is very ideal, while cyclopentolate is the best option like atropine to do cycloplegic refraction. My personal protocol in my own clinic, usually when I want to check the refraction and the fundus of a patient, I give him cyclopentolate twice and tropicamide for the last time. Then I have both effects: complete cycloplegia of cyclopentolate and full dilatation of tropicamide. But please take care. Take care, because some hazards may occur out of using eye drops. Atropine is very popular to cause fever and some redness. And many patients will be astonished having fever or redness after using atropine. It's one of the innocent complications, because you can just give him antipyretics and put cold fomentations, and most cases resolve spontaneously after maybe 1 or 2 hours. The most dangerous effect of cycloplegic eye drops is with cyclopentolate, because usually it crosses the blood-brain barrier. So being out of knowledge of that central effects, you may have disastrous communication problems with the parents, because if you give cyclopentolate more than 2 times in a child, especially if under age of 7, it will cross the blood-brain barrier. It may cause fits, convulsions, hallucinations, and the problem will come at that time because of the disturbed conscious level. So please be very cautious using cyclopentolate eye drops, and you have to know when it doesn't cause complete dilatation of the pupil. because many doctors may have this bad experience of putting cyclopentolate eye drops for 2 times, then the patient will not dilate well. Then he'll give the third time, fourth time, fifth time, sixth time, and the people is still not dilating well. Then the child will start convulsions, hallucinations, and disturb the conscious level. So you will be transmitted to the ICU. So please don't give cyclopentolate more than 2 times in your office, and don't expect from cyclopentolate to cause full dilatation. Toropicamide is a bit safer because it's it's not having too much central complications, but again, it can cause some mild fever, mild redness, and it doesn't cause complete cycloplegia. So your first visit with a hypermetropic patient, your aim is categorizing your patient. We have many boxes. At one of them, we have to put our patient. So we give the full cycloplegic refraction for the patient in glasses in the first visit. So the usual scenario is receiving a patient with esotropia that occurred or started few days or few weeks ago before presentation. Then the parents will tell you he started inward deviation, and you just check refraction. You'll find hypermetropia. You'll just give him glasses. Which glasses you give? You give the full correction with the full hypermetropia. And you can call him back 2 to 6 weeks after the first glasses. Because next time we'll put a diagnosis or I'll put a plan. So if you have a patient with hypermetropia and we checked properly the refraction after cyclopentolate twice, and he came again in the second visit after 2 weeks with fully aligned eyes, now it is clear it's a fully accommodative esotropia. Many times you will have unilateral amblyopia, so it will be combined with sensory esotropia. We have different categories of esotropia that we'll discuss later. So you have to know it's fully, partially accommodative, sensory. Is it essential, not corrected by any means of glasses? Is it consecutive, using wrong glasses or wrong surgeries or bad surgery before? Or it's accommodative non-refractive? Then the classic most common scenario is accommodative esotropia, which we call it accommodative refractive esotropia. And refractive esotropia refers to its refractive problem due to hypermetropia. So it's a hypermetropic patient with a normal ACA ratio, and you don't have much difference between near and far angles of esotropia. So it's a fully accommodative esotropia that will come fully corrected by glasses later on. But please, before sending your patient back home, just tell him what is success. Because many patients of fully accommodative esotropia will come to you again after 3 to 6 months or 1 year or 2 years, telling you your treatment plan is a failure because the child is still well aligned when he's putting on his glasses and is completely back to worst esotropia when he removes the glasses. And before reaching that point, we have to tell the patients from the start, we'll have glasses and will be dependent upon glasses for long years. And don't tell how many years. Tell them we have esotropia that will last for years and will be corrected only by glasses, and the esotropia will return back when you get off your glasses. Because it's hypermetropia, and this esotropia is just a symptom or manifestation of the hypermetropia. So don't expect to have less esotropia before reaching a point at which convergence is much less or hypermetropia is corrected. So don't give promises, and don't forget to tell them what's success of treatment of accommodative esotropia. And please, again, don't tell a number when the mother will ask you, when will we remove the glasses? Because many doctors, under the pressure of an aggressive mother, will tell them, we have to remove glasses by the age of 10 or 11 or 12. We don't know numbers about the resolution of hypermetropia, so don't promise, but just tell will last for years, and we can't promise. Then many times mothers will ask me, at which time hypermetropia will correct exactly to complete normal. Then I ask her back, at which age your child will height will be 1 meter 50 centimeters? You don't know. So it's a growth plan. We can't manage, interfere, or manage or modulate. So how can we predict the future refraction of a child of non-emmetropia child? Can hypermetropia increase? The answer is yes, it can increase. And myopia can decrease by the way. So many times we have what's called emmetropization, in which the hypermetropia will have different courses in different children. Because some hypermetropes, or many children when they are born, they have average axial length of 17 millimeters with a K reading of 55 diopters. And the adult is 23 axial length, while the K reading is average 43. Expectedly, from age 0 to age 18, we have a changing axial length towards growth that will turn the eye towards myopia, while the flattening of the K readings will turn the eye towards hypermetropia. So you don't know which one will exceed the other. Hypermetropia can increase if the flattening is faster than the axial length growth, and it can decrease if the axial length growth is faster. Then the child can be emmetrope for life if we have equal flattening of the cornea with axial length increase. So again, you can't predict hypermetropia will increase, decrease, or be stable. The same with hypermetropia, and finally, the same should exist with emmetropia. Then the second type of accommodative refractive esotropia, when you give the full correction with glasses, the child will come you again with residual esotropia with glasses. That's what we call the partial accommodative esotropia. It's hypermetropia with normal ACA ratio, but we have near-far disparity of 15% diopters or less. So it's very negligible near-far disparity. So we can neglect the numbers of near-far disparity in the accommodative refractive esotropia. Then please don't addressing surgery for that patient. You have to know whether this patient may be amblyopia in one eye. So please don't forget to check the vision each visit for your patients, just to put patching or penalization for the eye to be treated by amblyopia before sending for surgery. Then when it comes to speak about surgery in accommodative, refractive, partial accommodative esotropia, we'll ask yourself which angle to operate upon. Is it uniocular or binocular surgery? We'll do Faden or not, recession or fenestration. We have many options that will be treated surgically. And before that, we have to know we have different protocols. My personal protocol is by the augmented formula of measuring the largest angle of near esotropia without glasses and the far angle with glasses, which is the least one. And we'll take the average and to operate upon. Usually, I prefer doing bilateral symmetrical medial rectus recession. But before sending my patient for surgery, I have to tell them before. We are transferring your patient or your child from partial accommodative to a fully accommodative esotropia, because some esotropia should exist after doing the surgery without glasses. So the success target of partially accommodative esotropia is to have properly aligned eyes after doing our surgery with glasses. But without glasses, you have to tell them before surgery, we have residual esotropia without glasses. Then accommodative esotropia, which is the refractive, we have many different options. Usually we prefer the bimedial recession, but we have to take care. If you are doing surgery for very high hypermetropia, you have to reduce your numbers because the short eyes has different equations. So if you have very high hypermetropia, more than +5, you have to reduce the numbers you are used to do. Accommodative esotropia, which is the second type, which is non-refractive type. What is the accommodative non-refractive esotropia? Non-refractive type can exist with myopia, hypermetropia, emmetropia. So it can come with any refractive situation. It has high ACA ratio and near far disparity, it exceeds 15 prism diopters. So you have to know when we have our patient with fully corrected refractive error, regardless it's hypermetropia, myopia, or emmetropia cylinder, I don't know what's type, we'll send the patient to use glasses and it will come again with residual esotropia, which is more for near than for far. We have again to consider amblyopia therapy in any patient before addressing strabismus surgery, especially accommodative type, either refractive or non-refractive. Then, what is the predictors of having high ACA ratio? Usually, the most common type of high ACA ratio and accommodative non-refractive esotropia will come with neglected management of myopia. Because most myopes, more than -5, even if below age of 1, they will be start to be nearsighted. So they will exert much more convergence more than accommodation. So they will use many, many diopters of convergence, prism diopters, relaxing their accommodation, so they may have high ACA ratio. So this is the APOS protocol of treating myopia in emmetropic patient. If you have a child accidentally discovered myopia more than -5, you have to correct even before age of 1 year. And below or equals to -4 from age 1 to 2 years, and any myopia 3 or more diopters more than age of 2 years. Just to avoid having this accommodative non-refractive esotropia. Usually it's treated by bifocal lenses. So just to nullify the effect of accommodative convergence, we use added +3 for the near segment on his glasses. Regarding the distance refraction, we just put a +3 add to the near segment. If it came with corrected eyes, we can continue with bifocals till the age of 8 years. Or if it's not corrected, we have to run for surgery. We have many types of surgery for accommodative non-refractive esotropia, but we have only two indications, either non-corrected below the age of 8 or dependent on bifocals after the age of 8. We have many options like a slanting recession of the medial recti. We can do simultaneous recession with Faden on the medial recti, or we can do only Faden on the medial recti. So surgical treatment will come if the bifocals failed before the age of 8, or if it existed to be dependent upon bifocals after the age of 8. Accommodative non-refractive esotropia, we have many, many surgeries. Other than fenestration and Faden, we have other options like medial rectus fenestration. We can do in some protocols resection of the muscle. Sometimes some surgeons, I'm not one of them, are fans of doing simultaneous recession and resection of the same medial rectus for accommodative non-refractive esotropia. So before finishing my lecture, I'd like to end with this very simple case, just to send us a single message. 18 months old boy was referred to me with large angle XT after being operated for congenital esotropia few weeks before. He was a general ophthalmologist who operated upon. He examined the patient and he told me the child was 50 prism diopters esotropia since age of few months. He has no history of using glasses before. And he told me I operated by medial rectus recession 5 millimeters. So he came immediately after surgery with large exotropia. Large angle XT of 50 prism diopters with free motility. But when I tried revision of the cycloplegic refraction, I found both eyes are hypermetropic of +7. Full correction glasses were given. 6 weeks, follow-up, nothing new. The same exotropia was +7. So before going to the next slide, this child was not essential esotropia, it was accommodative esotropia. And for knowledge, many doctors expect classic type of accommodative refractive esotropia does not present before the age of 2, and this is true in many cases. But we have a category called infantile or neonatal accommodative esotropia, because the smallest age recorded in the literature is accommodative esotropia at the age of 4 months. So before going for diagnosis of bimedial recession for essential esotropia, you have to revise properly the refraction because the child was simply accommodative esotropia. What I did is exploration of the medial recti, and I did bimedial advancement with resection of one of the tendons, 4 millimeters. The patient came post-operative after doing advancement of 50 prism diopters of XT. Then another surgery was done by me, bilateral rectus recession, 11 millimeters with resection of the other non-resected medial rectus tendon, 5 millimeters. And the child came again with the same exotropia, maybe 35 prism diopters exotropia. All this with his glasses and without glasses. So hypermetropia, I excluded 1 or 2 diopters of the hypermetropia. I just gave undercorrected lenses. He came again with exotropia with and without glasses. So what I did is just alternate patching and follow up till he has orthotropic eyes 3 years later. Just try to compare the age from this picture to that one. So he exerted too many years just for correcting a mishap that can be avoided just simply by revising your refraction before giving a full diagnosis of essential esotropia. So my conclusion message is proper cycloplegic refraction and amblyopia management are the secret weapons in treating accommodative esotropia. Patient counseling regarding the pathology treatment success of accommodative esotropia is very, very important. Don't ever promise the patient or parents to get rid of glasses at which age. Adjust your surgical dose in high refractive errors. And finally, you have to put your decision before your incision. Thank you very much.
Thank you so much, Dr. Sameh Jalal.